Hi, everybody. Welcome. We're so excited to have you all tonight listening in. Hopefully you are excited to hear from Dr. Tan, Marilyn Tan. My name is Leah Groppo. I'm one of our diabetes educators and dietitians at Stanford Health Care. And I have the honor of getting to present with Dr. Tan today. So I have a brief introduction for her. So Dr. Tan is double board certified in endocrinology and internal medicine. She's a clinical associate professor of medicine at Stanford University School of Medicine. She practices general endocrinology, but her main clinical interests are outpatient and inpatient diabetes management. Her research interests also include diabetes and post-bariatric hypoglycemia, and she's also very involved in our teaching for our residents and our fellows, and she's also the chief of our Endocrine Clinic. So Dr. Tan has a lot of wealth of knowledge, and I kind of wanted to just start off with a quick story. So the reason why we decided to do this talk was because maybe 3 or 4 years ago, I was working with Dr. Tan's patients, and she actually introduced me to a type of diabetes that I was unfamiliar with and actually not tested on in my certified diabetes educator exam, diabetes type 3C. And so when I heard that, I felt so surprised, and I was wondering why I hadn't heard about it, read as much as I could, and definitely picked Dr. Tan's mind a lot because she was definitely the expert. And so hopefully tonight we can share some of the knowledge that we have and the ways that we treat patients living with diabetes 3C at Stanford Health Care. So without further ado, I will hand it over to Dr. Tan.
Thank you, Leah, for the kind introduction. And so I will start sharing my slides, and thank you to everybody for having me here tonight. So we'll talk a little bit about type 3C or pancreatogenic diabetes. So you've probably all heard of the different types of diabetes, type 2, type 1, or even gestational diabetes. These are usually the ones that we hear about in the media. So as a reminder, the normal healthy pancreas makes insulin, which is a hormone that helps to lower blood sugar. And then you have receptors on your cells that respond to the insulin in order to lower the blood sugar. In type 1 diabetes, this is an autoimmune destruction of the insulin-producing cells of the pancreas. And so this leads to high blood sugar due to insulin deficiency. Type 2 diabetes is the most common type of diabetes that we see, and the vast majority of information that we see online and on the media and on TV is around type 2 diabetes. For the vast majority of patients with type 2 diabetes, the issue is not so much insulin production, but rather a lack or insufficient insulin response, or you may hear the term insulin resistance. Now, there are other types of diabetes as well, and so I'd like to introduce a little bit about some of the lesser known diabetes. So other types of diabetes that you may hear about, as Stanford is a transplant center with a lot of complicated patients and patients on various medications for steroids and chemotherapy, we often see patients with steroid-induced diabetes. Then there's also post-transplant diabetes. And then less commonly, there's monogenic diabetes or MODY, and then type 3C diabetes, which is our topic of interest today. And then pre-diabetes, which is really kind of a pre-disease state where people who have that are at much higher risk of developing type 2 diabetes. So again, like I said, most of the information that you will see online, and actually most of the information from most of your healthcare providers, is probably going to be centered around type 2 or maybe type 1 diabetes, but there's really not that much on type 3C diabetes. So a little bit more about the basics of type 3C diabetes. In terms of demographics, it's actually more common than we normally think about. In Western populations, estimates are that it accounts for 5 to 10% of diabetes, mostly related to chronic pancreatitis or inflammation of the pancreas. And then we'll talk a little bit more about the chronic pancreatitis in a little bit. Many patients are misclassified either as type 2 or type 1 diabetes. For the diagnosis, usually there's some degree of insulin deficiency. Now, this can be absolute, where patients make essentially no insulin, or it can be relative, where they make some, but it's just not quite enough to bring down the blood sugars. There's often also the presence of pancreatic exocrine insufficiency, meaning a lack of digestive enzymes, which we'll also talk a little bit more about later, and then evidence of pathological pancreatic imaging, where some people have CT scans or MRIs or ultrasounds that may show chronic inflammation or atrophy of the pancreas. Importantly, there are also the absence of antibodies for type 1 diabetes. So whereas with autoimmune type 1 diabetes with pancreatic beta cell dysfunction, most of the patients have elevated antibodies against the pancreas, patients with pancreatogenic or type 3C diabetes do not have these antibodies. So let's talk a little bit about normal pancreatic function. The pancreas is this long organ that you see that sits below the liver, and there are different parts of it: the head, the neck, the body, and the tail. And all of these different parts secrete different enzymes and hormones. For exocrine function, this is where we talk about digestive enzymes. So there are enzymes like trypsin and chromatrypsin, which help to digest proteins. Amylase helps to digest carbohydrates, and lipase helps to break down fats. There are also pancreatic juices that go down the duct into the first part of the intestine to help with digestion. Our focus today will be more on the endocrine or hormone function, which is really centered around the islets of Langerhans. So the beta cells, which some of you might have heard of, are the main cells that produce insulin, which helps to lower the blood sugar. There are also alpha cells, and these make glucagon, which does the opposite and helps to raise blood sugar. There are also delta cells, which make somatostatin and helps to regulate other hormones. And then the gamma cells produce pancreatic polypeptide. Let's talk about the pathology of type 3C diabetes. Typically, there's impairment in pancreatic endocrine function. So there's some deficiency of the production of insulin and glucagon. With chronic pancreatitis, the most common causes are either due to alcohol, obstruction, autoimmune disease, or there are hereditary and idiopathic causes. We can also have type 3C diabetes or pancreatogenic diabetes related to cystic fibrosis. Patients may also have had pancreatectomies, and as Stanford does a lot of these surgeries, we often have patients who have had either part of their pancreas or their entire pancreas removed for either pancreatic tumors or pancreatic cancers. Less common causes can include hemochromatosis and fibrocalculous pancreatopathy. The pathophysiology involves really destruction of the pancreatic cells that make the normal digestive enzymes and the hormones. Chronic inflammation leads to pancreatic injury and progressive scarring and dysfunction. With exocrine dysfunction, again, those are the digestive enzymes. Once we no longer make enough of these, then we can have impaired digestion, malabsorption, and malnutrition. With endocrine dysfunction, as we have less insulin secretion, then the blood sugars go up. As we have less glucagon secretion, there's actually a propensity for low blood sugar. So as your body normally has these backup mechanisms to raise your blood sugar when it's too low, we lose that ability as well. How do we treat pancreatogenic diabetes? And what are our goals? So why do we care so much about blood sugar control? You've probably all heard that with type 2 and type 1 diabetes, we worry about diabetes complications. Patients with all types of diabetes and chronic high blood sugars remain at risk for these complications. So whether it's due to MODY or due to transplant diabetes or pancreatogenic diabetes, they share the same risks for diabetes complications. Microvascular complications refer to complications related to small blood vessels. These can include neuropathy of the nerves, nephropathy or kidney disease, or retinopathy involving the eyes. Then there are macrovascular complications, and these are the large blood vessels. This can include complications like heart disease, stroke, and peripheral vascular disease. Other complications related to high blood sugars can include a propensity for infections and also poor wound healing. It's important that we individualize A1C and glucose goals. So it's very critical that we remember that type 2, type 1, type 3C diabetes, all of these are different. Each individual is different, and the goals for blood sugar control should be different. There's no one-size-fits-all treatment, and there's no one-size-fits-all glucose goal. We have to take into account a lot of patient factors, such as someone's age, the risk of low blood sugars, even the cost of medications, long-term goals, like, if somebody has a poor health prognosis with metastatic cancer versus if somebody is young and otherwise healthy. So it's very critical that you talk to your doctor or your other healthcare providers about your individualized blood sugar goals. It's also important to maintain nutritional status, which Leah will talk more about later as she is the expert in this. Now, how do we manage type 3C diabetes? Lifestyle modifications remain kind of similar to what we talk to patients with type 1 and type 2 diabetes about. So importantly, reducing toxic and modifiable contributors to chronic pancreatitis, really trying to get at the underlying cause. So for patients with alcohol-related pancreatitis, really stopping all alcohol consumption, smoking cessation, medical nutrition therapy is also important. So it's important to maintain your nutritional status so that your whole body can heal properly. Improving insulin sensitivity. So in addition to not making enough insulin, some patients may still have insulin resistance, meaning that there are things that contribute to their lack of response. So being overweight, being very sedentary, these can all contribute to insulin resistance. So interrupting sedentary time and staying active can help improve your insulin sensitivity or your response to the insulin. And very importantly, even though most things you may read in the media about control of diabetes involves a low-carb diet, with pancreatogenic diabetes, patients don't necessarily need to be on a low-carb diet. Now, this does not mean that you can go on and have all the soda you want. We still want you to have good nutrition. But again, patients don't necessarily need to restrict carbohydrates the same way that we counsel our overweight and obese patients with type 2 diabetes. In terms of medications, pancreatic enzymes may be used to help supplement for digestion. Patients who don't make enough insulin often need to be on insulin. For some patients who do make some insulin, they may be able to get away with some oral diabetes medications. And importantly, for patients with a history of chronic pancreatitis, for example, or pancreatic tumors, it's important to avoid certain classes of diabetes medications because there may be an association of these medications with a higher risk for pancreatitis as well. Now, we have a lot of other tools as well, and this could be a whole other talk. But for example, we have continuous glucose monitors in addition to the traditional finger stick glucometers. These help give patients a lot more blood sugar data and can really help you monitor what's happening to your blood sugars with different food and activity and medications. And it really gives us a better picture of what's going on with your diabetes. Now, the traditional way to monitor is with finger sticks testing with your blood sugar, and these give us individual data points throughout the day. But really, these CGMs can provide a lot more information. There are also insulin pumps, which help to deliver insulin in a continuous infusion, and you can give yourself extra insulin for things like meals. But these, again, are not yet at the level of an artificial pancreas. So really, insulin pumps are an alternative form of insulin delivery, similar to using insulin syringes or insulin pens. So challenges of type 3C diabetes, like we talked about earlier, the absorption can be impaired. And even when we give back enzymes, the absorption and digestion can be really unpredictable. You may eat the same thing and take the enzymes 2 days in a row and have different responses. As we talked about earlier, because there's a lack of glucagon, there's a higher risk of hypoglycemia or low blood sugar because your body cannot compensate for that low blood sugar. And then there's the lack of endogenous insulin production. So we have to supplement with insulin injections, maintaining nutritional status as patients try to make sure that they're keeping up to date with their digestion and keeping up to date with the right calories and macronutrients. And most importantly, what I've found for a lot of my patients is just a lack of awareness and information, even from many of their healthcare providers. And so for people who don't see a lot of pancreatogenic diabetes, they just have no idea how to even start counseling these patients, what expectations to set. So really increasing awareness and information is our goal here. In terms of future directions, we hope for more improved automated insulin delivery systems to help patients better manage their blood sugar. Perhaps pancreas or islet cell transplants or stem cell therapy to help with pancreatic recovery. But at this point, really, it's most of the other tools that we talked about earlier.
tag team off of that, I really want to focus on our nutrition recommendations. So when we're thinking about diabetes 3C, we really want providers that understand the root cause and the etiology, like Dr. Tan. We also want to think really about our nutrition and our nutrition status. So I think Dr. Tan really alluded to the really great importance of thinking about not being malnourished and having adequate nutrition. And really for this recommendation, I think Dr. Google. I feel like a lot of people will go online and Google things, and really it's hard to find recommendations around diabetes 3C because it actually really needs to be so highly customized. There are so many different causes or etiologies where someone might become diagnosed with diabetes 3C. And so we really want to think about going to providers that can help create and look at you as a customized and a unique and individual person. But one of the things that I really like to focus on is prioritizing different needs. So when we're thinking about blood sugar control, especially somebody who's giving insulin and taking insulin, we want to think about reducing hypoglycemia. Like Dr. Tan had mentioned, when you have diabetes 3C, you have issues also making and producing and putting out sugar from the liver. And so that's something that we really want to be mindful of. This is a mechanism that really helps to kind of prevent some low blood sugars for people. So things are a little bit more variable and harder to control with diabetes 3C. We also want to think about assessing our nutrition status. So there are a lot of other things, digestion, maybe some not digesting fats and carbs and proteins as well, taking enzymes, pancreatic enzymes. And so this can really be something that we want to think about assessing. I always ask about bowel movements and what they're like. Are they floating, greasy, extra foul smelling? So we want to really get that full picture of somebody. Also, has there been sudden weight loss? So that's something else that we really want to assess and think about. Sometimes also when people are maybe post-surgery, post-Whipple surgery, and blood sugars are really just very flat. We're looking at data and they're not very variable. We always want to think, what's going on? Is this person eating? And if they are eating, maybe their enzymes aren't dialed in correctly because maybe they're malabsorbing and they're not actually taking in the food that they eat. Say they eat a sandwich and they're not actually absorbing the carbohydrates from the bread into their bloodstream. And so that's why blood glucose is also flat. We want to think about addressing digestion issues. And then also after we've really thought about hypoglycemia, we want to also reduce hyperglycemia. Like Dr. Tan had mentioned, really thinking about the micro and macrovascular issues, we really want to prevent those, but of course, making definitely very personalized goals. And then when possible, using continuous glucose monitors, really paint that full picture and help people to really understand where their blood sugar is going at different given times versus having to prick their finger all the time. And something that I really like to do is I like to sit down, share my screen, and really look at data with people that I'm working with so that we can look at the same data. It's the data that's going on in their body and really talk through it and talk through different meals, maybe when insulin is being given, so we can kind of think on the same page. So if you have a provider, really maybe seeing if you can look at your glucose data together and really look at pattern management together to try to understand. Because in the end, you might have maybe 30 to 60 minutes with a provider, maybe once a month, maybe once every 3 months, depending, but you're the one who's in the driver's seat 24/7 making these decisions. So in our sessions, we can really educate and empower you to make these choices and understand what's going on and why things are going on. I think that's the best. Some other tools for managing blood sugar. So I always like to think about timing of insulin injection. So if you have diabetes 3C and you're taking insulin, what time are you taking it? Are you taking it at the first bite of your meal? Are you taking your insulin after you eat, maybe you're having a lot of nausea and vomiting and you're not feeling well, not sure how much insulin to give because you're saying, oh, sometimes I feel like eating the whole sandwich or the whole meal, and sometimes I only really get a couple bites in. So really thinking about what that timing in it is. Our really ideal time of insulin delivery typically is around 20 minutes before first bite of food, if you know the food that you're going to consume at that time. If you have a lot of nausea or maybe potentially vomiting at that time, it's maybe good to give insulin a little bit later when you can figure out how much you can consume. And then also, if you are having issues with nausea, thinking about having juice on hand or a really simple carbohydrate source close to you, that if you do start feeling really not well, you can make up those carbohydrates so that you're not, you didn't give insulin and not have extra carbohydrates. You can sip that juice so your blood sugar can still stay steady. We also like to really think about focusing on carbohydrate counting, so counting the carbohydrates that we consume. And sometimes for some people, adding extra insulin for higher fat or higher protein meals can be something that we recommend. It's something that for diabetes 3C, I really like to evaluate the glucose data before strongly making that recommendation and thinking about what foods are going on, because we really want to prevent low blood sugars. And then definitely looking at the types of carbs that you're consuming and how processed a carb is. So for example, I think when I was going to school to become a dietitian, this was definitely over a decade ago, we kind of thought grams of carb are just grams of carb. If you eat 60 grams of carb of one food or 60 grams of carb of a different food, for example, maybe a 60-gram big bowl of rice or a 60-gram big bowl of rice noodles, it would have a very similar glucose rise. But in the last decade or so, we've really found that different foods have different blood sugar effects and different abilities to raise our blood sugar. For example, in this slide, I just put a bowl of rice and then I put rice noodles. So rice noodles are made from rice flour, and so they're more processed, and then they're recooked, rehydrated. And so actually rice noodles are going to raise blood sugar higher faster than even a bowl of just white rice. So that's something to note, that the foods that you eat will have a different blood sugar raising effect. Not that we want to count the rice, the noodle bowl, and give more insulin for it, but that helps us understand the timing in which we want to give our insulin. So faster digesting foods can get a little bit more of a pre-bolus. But again, like these puzzle pieces, you're definitely a unique individual, and we want to make customized goals. So thinking about when to check, this is something that I wanted to highlight. I think for us, we really, if people can get on a continuous glucose monitor, insurance will cover it. That is a great option because it does give you blood sugars, and it gives you trend lines. It can tell you, for example, maybe your blood sugar is 140, but maybe your blood sugar is 140 going to 70, or maybe it's 140 going up to 260. So it can give you arrows and predictions that can also help with management. And it can really teach you about your body's digestion and how you're absorbing the foods that you eat and how it's affecting your blood sugars. If you don't have a continuous glucose monitor, really thinking about very intensive checking if possible, 6 to 10 times per day, thinking about before meals, because if you're on insulin, that's how you're going to know if you need to give a correction dose, give a little bit more insulin based on the food that you will eat. The one thing I do also mention is a concept called stacking. So you don't want to always overcorrect if your last insulin injection was 3 to 4 hours earlier, because that's still a moving target. So your insulin from that prior injection is still working. You want to think about maybe testing 1.5 to 2 hours post meal, trying to be under 180, but again, that can definitely be very customized. For some people, less than 200. It just depends. Before bed, so you know what your blood sugar is before bed, if you're going to be physically active, or maybe you have a day full of lots of doctor's appointments. I check blood sugar a little bit more those days because you're probably up and moving and using your muscles more than usual. If you have any low blood sugar symptoms like cold, clammy, sweaty, shaky, some people say it just feels like all the energy was sucked out of them. So if you have any of those low symptoms, you can definitely, I would recommend checking. And then also if you're going to do anything that you really want to make sure that you know where your blood sugar is at. I'm a dietitian, so I always have to put in this carb slide. I feel like I just want to make sure that everybody's on the same page of knowing when we're talking about carbohydrates, what we're talking about. So definitely all grains like breads, rice, pasta, tortillas, cereals, also starchy vegetables. So this is a big one like potatoes, peas, corn, winter squash like butternut squash. So these also all have more carbohydrates, beans and lentils, fruits, dairy products, and then of course sugary foods. So on this list, I think like Dr. Tan had also mentioned, we don't recommend a low carb diet, typically for diabetes 3C. We recommend a diet that has adequate amount of carbohydrates. And as a dietitian, I really don't like to label foods as good foods or bad foods. They're food and hopefully foods that we can enjoy. And so these are all just different options painting the picture of what a carbohydrate is. So I wouldn't say that they're unhealthy or healthy options. They're just different options of carbohydrates. So to go back a little bit more around the rice and the rice noodle example, one of the kind of ways to think about how a blood sugar is going to react in your body or a food, a carbohydrate, is thinking about how processed is the food. So if the food is very processed, like in this example, high fructose corn syrup, that's going to raise your blood sugar higher faster. Your body doesn't really need to do any work to get that sugar into the bloodstream. It's basically ready to go. But if we were to sit and eat an ear of corn, our body actually does need to break down those starches. It starts the digestion in our mouth with our amylase, enzymes breaking down the carbohydrates, and then it further goes down into our digestive tract, and there's a further breakdown. So it definitely needs a lot more. And then in the middle, I have cornmeal and corn flakes. So also, I don't know if you've ever had corn flakes, but even the zero sugar corn flakes, so no sugar added, just corn, really can spike blood sugar because it's very easy for your body to digest. Most cereals are. So just knowing that not all carbohydrates will affect your blood sugar the same. And because I think that sometimes not being able to predict your blood sugar can be very frustrating for people, especially people who've kind of almost stumbled upon diabetes 3C, maybe going through other medical conditions. It can definitely be very frustrating trying to also manage blood sugar. So know that there are a lot of extra variables inside your body and outside of your body. Also thinking about nutrition facts. So we had an original label. All of them actually in 2022 should be now converted to this kind of new label that we're looking at. But the really big thing that we want to think about is total carbohydrates. So we want to look at, of course, serving size to know how many, what the portion is for the grams of carb, but we definitely want to look at total carbohydrates for nutrition facts. I just wanted to paint a couple, just two different meal examples, because since I'm a dietitian, I love to look at food. I love to think about food all day. So that's definitely my job. So for this meal, if we think about carbohydrate counting the South Asian meal, if we look at the sambar, I would say a cup of sambar, which is like a lentil-based soup, is about 30 grams of carbohydrates. These veggies, for example, I would actually count them as 0. They're all pretty high fiber. For diabetes 3C, I would say this is 0. If you wanted to be very precise, I'd say this cup is probably 3 carbs. You could add it if you wanted to. And then the chapati or the tortilla is about 12 inches, 30 carbs made from flour. So this gives us a grand total of 60 grams of carbohydrate. So when I look at a meal like this, I also want to think about maybe looking at pre-meal blood sugar before this meal, thinking about how many units of insulin you're going to give based on the 60 gram of carb. Everybody has a different carb ratio. So maybe your carb to insulin ratio is 10, for example. So you would give 6 units for this meal, plus if you have to add a correction factor because your blood sugar is above the goal that's set. Some people with diabetes 3C maybe have a 1 to 20 carb ratio. It just depends. I would ask your doctor. And then for a meal like this, because it's going to raise blood sugar a little bit higher faster, and it's lower in saturated fat and a little bit lower in protein, I would give this a pre-bolus of at least 20 minutes. Of course, depending on where your blood sugar starts before the meal. Just one more example. So in this, salmon, I would give 0 grams of carb unless there's like a sweet sauce on it, which you can figure out. Daikon, which is right by the salad, just kind of like a grated radish, no sugar, no carbs to that. Rice in general, a cup of rice is about 45 grams of carbohydrates. Veggies, so in different Asian foods, there can be some sugar added or carbohydrates added. So typically, I'd say this is 6 grams of carbs. There's a Japanese egg omelet, and you actually have great flavor with it. And you also add a little bit of sugar, so that's 5 carbs. And then soup and veggie 5, so 61 carbs. And again, for this meal, I'd also pre-bolus this example. I just wanted to paint a couple pictures because I always feel like presentations are a great opportunity to highlight some delicious looking food. Hopefully you all got your dinner in already and I didn't make you further hungry. Another thing to really think about are foods to limit. So in general, I typically have a very flexible sort of outlook as a clinical dietitian at Stanford, but I will say that with diabetes 3C, especially if there are any digestive issues going on, I really try to limit and recommend no sugar alcohols. So sugar alcohols are things that have like the all on it, like erythritol, xylitol, sorbitol. So these types of foods, and really what they do is they pull in a lot of, they can pull in some more water in the intestine, but also they're not fully absorbed into the bloodstream. So some of it is left to also go into your intestine, your large intestine, and the bacteria actually get really excited. It's almost like they're used to just getting little pieces of roughage and fiber. And then one day with sugar alcohol, your gut bacteria then got a big birthday cake. They got this highly sugary type of molecule and they jump on it and they feed on it, and they can create a lot of gas and bloating around sugar alcohols because only half of them are really absorbed into the bloodstream and the other half end up in the intestine. So this can definitely exacerbate if you're having any GI issues. So I try to just kind of limit them. And also for diabetes 3C, we typically aren't recommending a significantly low carb, low calorie diet unless it would be indicated. But for most people, it's just an adequate amount of carbohydrates. Typically people have sugar alcohols if they're trying to do a low carb diet and trying to eliminate sugars from their diet. Here's just a nutrition fact, and it shows where the sugar alcohols are. So under total sugars and added sugar, there would be a sugar alcohol section. And if you don't see that, it's not one of the FDA mandated parts of the nutrition fact. You can also look for the common names. Other foods to limit. So in general, thinking about fruit smoothies, so or like an acai bowl or something like that, that is going to be very high in sugar and elevating your blood sugar very rapidly. I'd say trying to maybe have less of those. But I would also say that if you add maybe some Greek yogurt or some protein or nut butters or avocado to that smoothie, it would be an excellent choice because that's going to slow down your digestion and make it not as blood sugar spiking. It's just really hard for the body and also hard for the insulin, if you inject insulin, to meet the needs of a plain fruit smoothie because blood sugar will rise very rapidly. And then also soda or juice. So in general, we really want to kind of keep these to treating low blood sugar just because it's really hard for the body and also hard for insulin that we inject to really kind of meet the needs of such a high blood sugar spike. But it's good to have them on hand if you have low blood sugars or bring them with you. I like those little kid juice boxes to treat. Typically, we recommend half a cup or 4 ounces. They normally are like 5.3 ounces, but that's pretty close. So to start summarizing, just some key takeaways that I want to hopefully have everyone kind of think about is really thinking not all carbohydrates are going to act the same in our body. And so hopefully that's not too big of a source of frustration. Getting connected to somebody who's a dietitian and a diabetes educator, thinking about reviewing your own data, and definitely reviewing your data with your doctor or your dietitian, and maybe even asking the question, what are you looking for when you're evaluating? What patterns are you seeing? Where do you look first? So if you're looking at my data, what are you looking at? Which numbers? What ones are the most important to look at? Are all great questions and things to really kind of have a great conversation with your provider. Thinking about kind of getting enough nutrition. So I think sometimes people always think with diabetes, maybe it's more around restriction, carbohydrate control, less carbohydrates, less food in general, less calories. But I'd say typically for diabetes 3C in general, we actually aren't into the game of less. We're into the game sometimes of more. There's been a rapid weight loss, or if there's some digestion issues with stool, or healing from surgery, things like that. So it's typically not the same recommendation. So definitely very customized. Thinking about preventing lows, especially lows at night. So when I'm thinking about counseling somebody who has a continuous glucose monitor or is checking blood sugars, I'm thinking about how do we really make sure that they're not getting lows at night, and what types of foods are they eating before bedtime? Can they have a bedtime snack that can help sort of sustain them over the night? Things like that. For example, maybe if someone doesn't have a continuous glucose monitor, are they waking up in the middle of the night with sweaty sheets or cold and clammy? Maybe that's an indication that their blood sugar has been low at night. And then in that case, we could think about what that nighttime blood sugar looks like, involve the doctor, and kind of problem solve that together. And that would be a really great case to try to advocate for a continuous glucose monitor. And then also, like Dr. Tan mentioned, really there can be more malnutrition, and then the counter-regulatory hormones are maybe not as helpful in helping us raise our blood sugar, so from our liver, and so we really have less of a safety net. And then definitely monitoring our bowel movements, and if there's any big changes, definitely sudden weight loss or changes with our stool, like steatorrhea, so loose or greasy or floating stools, extra foul smelling, which would indicate that fat is not being absorbed and digested well with the lipase. And then really thinking about maybe we need to adjust our adjust bolus timing based on the different foods that we have. So maybe it's not really around lowering our carbohydrate intake. Maybe it's around how do we time our insulin based on what we're eating. And then really trying to make balanced meals with carbs, proteins, and fats at each meal, and adding in snacks if we can. So that is the end of our presentation. So Dr. Tan and I really wanted to take some questions. We had some questions come in, I think, in the chat as well. And maybe just to start off, I think that maybe I'll ask Dr. Tan one while I look at the Q&A. So somebody was asking actually before I talked, Dr. Tan, if diabetes 3C could be caused by extreme hypoglycemia.
You said hyper or hypoglycemia?
Hypo.
Hypoglycemia, I don't think so, but type 3C diabetes may have a contribution. Actually, well, we don't really call it type 3C, but with some patients with severe type 2 diabetes for a very long period of time, sometimes if the blood sugars stay very high for a long time, the pancreas can actually get kind of burnt out, where people get kind of this mixed picture where they don't have full pancreatic endocrine function as well as insulin resistance. But as far as I am aware, hypoglycemia does not lead to pancreatic dysfunction. However, it does have a lot of other dangers, which is why we're particularly careful about it, especially for patients with type 3C diabetes who don't have the same body mechanisms to try to fight it with the glucagon secretion.
Yeah, definitely. I agree. I think this is a nutrition question. So if type diabetes 3C raises blood sugar, why do we not want to recommend just a low carb diet and put everybody on a low carb diet? So I really would say that with this very specific type of diabetes, we do find a lot more risk for malnutrition. And oftentimes these people who are presenting with the pancreas and the exocrine pancreatic function diminishing, there basically is a lot of issue around, can we really absorb the food that we're eating? So are we able to break down those carbohydrates, fats, and proteins that we eat? And we do see a lot of malnutrition. So adding in a low carb diet on top of that typically will not give them adequate nutrition. Also, simultaneously, sometimes these patients are also going through other treatments, maybe for cancer, maybe healing post-Whipple or healing post-surgery. And so these are definitely patients we really want to focus on having enough protein and enough calories in. So we typically don't recommend a low-carb diet.
I guess the next follow-up question, I can answer that. So for those who are trying to control their type 3C through diet or lifestyle, when do they need to go to the next level, like medication or insulin? That's a great question. So usually the blood sugars will guide us and let us know when we need to be more aggressive about medication or treatment. So one thing that one of your providers may check is a C-peptide level. That's a lab that helps us to tell us how much insulin your own body is making. And so we have to look at this in the context of your blood sugar as well. So for example, if your blood sugar is actually very low at the time, it may be normal for the C-peptide to be low. And what's more interesting is to see where that C-peptide level is when your blood sugar is a little bit higher, to see what your pancreatic response is. So if your C-peptide is extremely low, for example, you had a total pancreatectomy, well, then that tells us you're not making any insulin and you need to use insulin. But if your levels are in normal range, then maybe you can get away with oral medications first. It really depends on how high the blood sugars are. So for example, for patients who are averaging blood sugars in the 400s, 500s, they probably need insulin. But if your blood sugar is only mildly elevated, sometimes we can use certain medications to help your pancreas secrete a little more insulin for food, or have other mechanisms to help with the diabetes control. And getting as a follow-up to that question, what should be the aim of blood sugar levels? Like we talked about earlier, A1C and blood sugar goals should be individualized. So for the average patient, we usually say that the A1C, or your average blood sugar over 3 months or so, should be under 7%. Now, the A1C is not a perfect measure. It tells us an average. It doesn't tell us how you got to that average. That's about an average of about 154 milligrams per deciliter. But again, it doesn't tell us if you're averaging between 50 and 300, or if you're averaging between 130 and 170. So really getting either that continuous glucose monitor data or that finger stick data is really critical to helping your doctor decide on how to better manage and adjust your medications. And again, like Leah said earlier, a lot of it also depends on your comorbidities and what your goals are. So for example, if you're 90 years old with pancreatic cancer, we're not so concerned about higher A1Cs increasing your risk of kidney disease 20 years down the line. Alternatively, if you are a 21-year-old drinking too much alcohol, then I would say, sure, aim for an A1C of 6.5. You've got a lot of time ahead of you. Quit drinking alcohol, really work on those lifestyle changes. You could afford to be more aggressive with your control.
Yeah, excellent. Such a great thorough answer too. This is another question about what recommended annual diabetes specific eye exams and other tests would you recommend? Or do you think that the recommendations for eye and the different screenings are more for people with type 2 diabetes with uncontrolled blood sugar? So this person's well managed.
Yeah, so that's a great question. Actually, for type 2 and type 1 diabetes, we have slightly different recommendations. So for example, for patients with type 2 diabetes, they often don't know that they have diabetes for many years until they're diagnosed. And so we start a lot of the early screening right away, such as checking a urine microalbumin for protein leakage in the kidneys. But for example, with patients with type 1 diabetes, it's usually fairly obvious when their pancreas completely fails. And therefore, we usually give them a little bit of time because we know that they're not going to develop these complications in the first 5 years or so. Now, on the other hand, with type 3C, it's a little bit unclear because sometimes it can be slow and progressive. So typically with our type 3C patients, I personally screen them the same way that we do for type 2 patients. meaning annual lipid panel, annual kidney function, and urine microalbumin, annual eye exam, annual foot exam, and just making sure that they continue to stay well controlled as you've been doing.
Yeah, great. I think there was also a question in the chat talking about for pre-bolusing, the type of insulin. So we're talking about mealtime insulin. So insulin that you give with meals or correction for the 20 minutes pre-bolus. And then also there was another question that came in before our talk asking if maybe Asian food was a contributing factor to diabetes 3C. So I'm happy to answer that. So I would say Asian food is definitely not a factor in risk for having diabetes 3C. Like Dr. Tan had mentioned, really, maybe it's around like cancer, or maybe it's around surgical or some type of acute pancreatitis or chronic pancreatitis related, but not based on diet. So you can be well assured that it's not based on any type of diet, Asian or any different type of diet that's going to cause diabetes 3C. And then Dr. Tan, someone's also asking if pancreatitis is caused by medications, can it be reversed?
So usually when we talk about pancreatitis, there's acute pancreatitis and then there's chronic pancreatitis. Acute pancreatitis is usually when people present to the hospital or to their doctor with severe abdominal pain. They have elevations in the enzymes from the pancreas. And usually these episodes can last a couple of days. And then usually we have them do some rest, take it easy with the food. They may end up in the hospital with the need for pain medications and really trying to get at the underlying cause. So for example, if it was due to a high triglyceride level, which is a type of cholesterol, we usually have them on a very low fat diet and don't let patients eat, and then that acute episode can get better. Similarly, if it's due to trauma, for example, from a procedure, then we give them a couple of days and that acute episode can get better. Now with chronic pancreatitis, this is due to long-term inflammation where we start to see scarring of the pancreas, and usually the pancreas does not regenerate. But in the short term, the function can be affected by acute inflammation or short-term inflammation, and as that wears off, the pancreatic function can improve. It's just long-term with chronic pancreatitis, or for example, if you have pancreatic surgery, the pancreas does not regenerate, unfortunately.
Yeah, great. And this is also another question. Somebody's asking about fast-acting insulin like Lispro should be given right before first bite or should still be given 20 minutes before first bite.
So I know Leah talked about this earlier. I usually recommend that people give it at least 20 minutes before, just like Leah said. Once in a while, we do have some exceptions. So for example, patients with very slow digestion or gastroparesis, sometimes they don't digest the food right away. And so this is where actually having a continuous glucose monitor can be really helpful. And different people digest different foods at different rates, like Leah said. So for example, if you have a banana, your blood sugar will shoot right up and come right back down. And so that's where it's really critical to have the insulin on board. Whereas if you have something with more fat and protein, your blood sugar may go up a little bit more slowly, and that may buy you a little bit more time for that short-acting insulin to kick in.
Yeah, and another great thing to think about is if you like to have fruit or bananas or tropical fruit that might spike your blood sugar, thinking about having it maybe with some nuts, or if nuts are hard to digest, some nut butters, already pureed nuts, can help elongate some of that digestion time and match better with insulin. Dr. Tan, somebody is asking, who's the best person to manage pancreatic enzymes after Whipple surgery?
So this kind of depends on where you are at. So every hospital and every medical group is a little bit different. Sometimes the surgeons manage this, and sometimes it's the gastroenterologist because they also manage it for other patients with chronic pancreatic exocrine insufficiency. Sometimes it's the endocrinologist. So it just depends on where your medical care is and how things are kind of divided between your different providers there.
Great. And then this is another question if fasting helps with pancreatitis. I think you mentioned it. But...
Right. So if the pancreatitis is related to, if it's an acute episode related to, for example, high triglycerides, related to dietary fat and high blood sugars, then yes, fasting can improve that and just give the pancreas a break to let that inflammation calm down a little bit. However, if your pancreatitis is due to other things, the chronic pancreatitis, fasting does not help in that situation.
Yeah, great. I think we've answered all of these questions. So I don't see any more questions in the chat box. So I think at this time, I just want to say thank you all for joining. We hope you found it informative and hope you have some new things to think about. And just to really thank Dr. Tannen for her time and her knowledge today and sharing that with us.
Thank you, Leah. I found it very educational for me as well.
Oh, great. Great.
Okay.
Bye, everybody.
Bye, everyone.